Alright guys, welcome back, and today we're going to talk about atrial rhythms. And so a couple little basic things, and when we get into the rules of how to determine what rhythm is what. So atrial rhythms actually originate in the atria somewhere other than the sinoatrial node. And it's very important to understand that fact, especially when we're going to diagnose what these rhythms are. We want to kind of think of this, is it coming from the SA node or is it coming from somewhere else above the atria? And it's important, again, to understand that. So again, the wandering atrial pacemaker. Now this one will drive you nuts, I will tell you that right now. So the pacemaker, it wanders between the sinus node, the atria, and the AV junction, okay? So there's some little spot in here. There's some little spot, whether it be this little spot right here, and when it gets really tricky is when you have multiple spots. So you might have a spot over here that's firing off, or you might have a spot over here that's firing off, or again, this guy can spot it. So again, each impulse originates from a different focus. So that's what the problem is. Well, how do we tell that? So the conduction could be slower, it could be faster, and then the conduction through the ventricles actually is normal usually. So that's the good news. It's just receiving a signal. So, matter of fact, one of the things that we use to detect this, and let's stop about it and think about it physiologically. So this spot over here, it might have a different looking P wave shape. Okay, where the normal P wave, QRS T, and normal P wave, QRS T, and then all of a sudden it's going to do, might give you that biphasic T wave. Well, why would it give you a biphasic T wave? Remember that whole negative positive thing that we talked about with the electrodes? It's having to travel farther in a different direction than what it normally does. So therefore, you're going to see weird P waves that happen, okay? So again, the irregularity of this, by the way, is going to be slightly irregular, just slightly. Matter of fact, you're probably going to have to break your calipers out to probably see it. The rate is usually normal. It's usually between 60 and 100 most of the time. The morphology changes on the P wave, and that's the key one to this one. So you might get a P wave that's doing this number. Again, you might get an inverted P wave or a biphasic P wave, or if all the P waves are shaped like this, then it might go like this. And you're going, wait a minute, that's barely a P wave. Or that P wave, the next one might be a normal, and then a normal, and then all of a sudden it looks like this. Wait a minute, that's kind of crazy for a P wave. And then you might get another normal and another normal, and then, maybe flatter, And you're sitting there going, wow. And the reason this is because it's coming from a different spot. Good news is the PR interval is usually less than 0.20 seconds. But remember, and we're going to click back to this slide right here. If the spot is coming from here, it's going to take a little bit longer to get over here. So that might extend out your PR interval just slightly. And then you have your QRS. But by the way, it usually doesn't go over the 0.02, okay? Or the 0.20, sorry. It doesn't go over the 0.20 at that point. All right, so clicking back to this slide, we saw that. Let's see an example of it, all right? So notice here, I got a P wave. I got a P wave. I got a P wave. Oh, wait a minute. Whoa, hell, that P wave is really short. Yeah, that's not good. Oh, wait a minute, it's changing here too. And so we've got it coming from a different spot, okay? Usually, guys, this is a 6-second strip. I will tell you that usually to see a wandering atrial pacemaker, it's probably good to maybe have 10, 15 seconds worth of strip to be able to see it. So, again, and by the way, these are most of the time benign. It does not cause too many problems. But again, it usually means that they've got some irritability in the atria somewhere that's kind of overriding the SA node. Again, usually nothing malignant, but again, it's firing from a different spot that it's not supposed to. All right. Now, the next one, a premature atrial complex, a PAC. Kind of short. So there's an irritable focus somewhere in the atria, and it fires prematurely, which causes a single ectopic beat. All right. The key thing is this is a single beat and not an entire rhythm. So understand this only happens the one time. And our rules on this, again, it kind of depending on the underlying rhythm, and I'm going to talk about that when we actually take a look at the strip. Again, usually your PR interval no more than 0.20 seconds, but your P waves, the early beat differs from the sinus P wave. You'll be able to see the difference of the P wave. And it's usually just a little bit quicker than it's supposed to be. So let me get to the example of this. I think it shows it a little bit better. So I want you to kind of ignore this for just a second. Look at this part of the rhythm strip over here. Okay, we got P wave, QRS, T. P wave, QRS, T wave. The T wave's inverted. That's okay. It's not a big deal. Okay, but look back over here. Look back over here. Notice how this P wave, it started a whole lot earlier than it was supposed to. Okay, and matter of fact, some might even argue, wait a minute, this might be the end of the T wave. And I would say that that's a very actually valid argument, except for notice how that little peak goes a little bit higher and looks a little bit different. Okay, now the good thing is, by the way, PACs, guys, the P wave is usually upright. And this is a good thing to remember, especially when we start talking about the premature junctional contraction. Remember, this signal, even though it's a premature atrial contraction, it's still going as far as the negative to positive, right? It's still following this usual same flow. So most of the time, guys, the PAC is upright. Now, the only thing physiologically that's kind of bad about this is that you didn't have a good repolarization period. But again, not a big deal usually. They're usually very benign. But notice again that this R to R interval, see how short that sucker is compared to the rest of them, okay? So this is one of these that you look at the strip in its entirety. And notice it only happens on the one beat, okay? Now, you might get a few that string together over maybe 20, 30 seconds. Again, most of the time, benign, we just need to be aware that it is actually happening, okay? Again, usually due to some sort of irritable focus, again, in the atria, there's a little spot that's firing off because there's, for some reason, it's irritated, all right? But again, most of the time, doesn't cause too many problems. All right, not to be confused with this guy right here. So atrial tachycardia. Now remember when I said that it was a single beat for the PAC? Well, think of that PAC on steroids. Okay, there you go. You got atrial tachycardia. So this is a single irritable site when the atrium fires repetitively. It's always, I repeat, always above 150 beats per minute. Most likely somewhere around the 200 to 250 beat range. All right. Now, the single irritable focus within the atrium. Again, I want to stress that one. Single irritable focus. So your P waves are going to be there. And then again, the atrial P waves, they differ from the sinus P wave. And the problem with atrial tachycardia is usually you don't see the P wave because it's lost in that preceding beat's T wave. Okay? But the rhythm is so fast that you can't tell the difference. Now, this might be a good time to talk about the use of the term supraventricular tachycardia. This seems to be a favorite one because what usually people will do, especially paramedics, is they'll have a narrow complex tachycardia and they will call it supraventricular tachycardia because they can't really diagnose it as atrial tachycardia. I sort of kind of subscribe to that. I think that you guys are better than that. Again, supraventricular tachycardia is any narrow complex tachycardia over 150 beats a minute, or something that we know for a fact is coming from above the ventricles, all right? My point to that is that if you've got a narrow complex, if it's above what that patient's sinus rhythm is, I'd much rather you call it atrial tachycardia than supraventricular tachycardia. Can you call it supraventricular tachycardia if it's above 150 beats a minute? The answer is yes. However, I'm more of a fan of, if I know what the heart rate is, I can probably discern what it is for this patient. So let's see here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21. So I got a rate of 210 beats a minute. Again, the faster way to do that was to find this one right here, 300, somewhere between just south of 300 and 150. So like 220. Again, we could kind of say that because of the number of the little boxes. It doesn't matter. It's fast. It's way too fast. And usually, if I can't see the P wave, and it's narrow in nature, that's usually your clue that it is some sort of atrial tachycardia. Okay? Now, again, can I actually see the P waves in here? I got a P wave. I can't really see them. And that's one of the biggest. Maybe on this one here I can see it. Yeah, I can sort of see it here. I can sort of see it here. I can sort of see it here. Maybe, possibly. My point is that it's actually too quick to count. Now I could take a look at another lead maybe and see a better P wave and be able to go, oh yeah, there's P waves there. So I know that it's not coming from the sinoatrial node. Again, 210 beats a minute, guys. Unless this is a 5-year-old, probably not going to be sinus tachycardia. Okay, now, speaking of this, and this is kind of our real important point. So if I have a sinus tachycardia, I want to treat any tachycardia, I want to treat the underlying cause. If I determine that it is atrial tachycardia, that is an electrical problem. And that we fix it with either slowing down the electrical system or resetting the electrical system. If they're stable, we can use a drug, adenosine. Adenosine works really good. If adenosine doesn't work, your cardizem actually is the second line drug for this. It will slow it down just a little bit to where it slows the conduction through the AV node, so that and it actually has some properties that's going to slow it down. Most of the time, guys, adenosine works really good on atrial tach. Okay, atrial tach, adenosine works really, really good on it. Okay, and of course you can do an electrical reset, which is a cardioversion. I would only do that on my unstable patient. Okay, if again they got the cash, they get the joules. We all know what cash is. Crushing chest pain, altered mental status, severe shortness of breath, and hypotension. All right, and that would be a blood pressure below 90 systolic. All right, well, they got a blood pressure 88 systolic. Again, but they're looking at you, they're talking to you, they know what's going on, and they got no other symptoms. I might not want to exactly weld them just yet. Okay, stability is not a black and white issue. It is truly it can be a very subjective thing. All right, atrial flutter. So what happens is these create flutter waves. There's a single irritable focus in the atria. Now the good news is that your AV node kind of goes, this would be somebody from administration coming in pretending to be Rod. Okay, and they come in and they start barking orders. Now, me and Mel and Dave as lead instructors are going to go, wait a minute, we can let this order through, and we can let this order through, and we can let this order through, but we're not doing this number right here. So there's kind of an intermittent block to it. Now, so the good news is your atrial rate here is about 250 to 350 beats a minute, but your ventricular rate's going to depend on how many signals that the AV node lets through to the ventricles, okay? Now, again, we can have, if it does bang, bang, and then we let an order through. All right, that one's probably still going to be a pretty fast heart rate. Bang, 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 probably around 100, bang, 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 and then we let a signal through around 75. So, again, the rules of this, again, and let me show before we go back to the rules here. So this is an example of atrial flutter with 4-to-1 conduction. There is actually a flutter wave in here. There's a flutter wave here, a flutter wave here, a flutter wave here. It lets it through. Flutter wave here. Actually, that's embedded in the T wave. I could probably say this is a 3. I guarantee you guys, if we were to look just at the atria, there would be a 4th wave here. And if you time this out, if you time these guys out, they're going to be regular, by the way. My lines are horrible here. But if I was to take my calibers and put one here, and I put one here, and I put one here, I guarantee you it's probably going to be regular, okay? More than likely it's going to be regular, all right? Now, notice how, but my atrial rate here is probably around 250 to 300, but my ventricular rate, it's not too bad, actually. 1, 2, 3, 4, 5, 6, 7. Hey, I got a heart rate a ventricular rate of 70. Hey, that's actually pretty good. Physiologically, it's simply squirting the blood down to the ventricles in a rapid succession. Now, the problem is it's going to really tire out your ventricles. It's actually not a good thing to be in, but actually most of your patients in a flutter are probably going to be pretty stable. When they're not going to be stable is when you start getting this guy to conduct, or this guy to conduct, or this guy to conduct. When you get up to the 3-to-1 or the 2-to-1, or heaven forbid, you get to that 1-to-1. If you get a 1-to-1 conduction, you're probably looking at a ventricle rate of 250 to 350. Yeah, that one you're probably going to need to reset. And when I say reset, I'm meaning probably via the electrical means. All right. So your again, the atrial rhythm is regular. And by the way, you can have an irregular. Can this change to I let 2 beats go and then let an impulse go, then let 4 beats go and then let an impulse go, then let 3 beats go and let an impulse go? It does happen. It's rare, but it does happen. Okay. So if you're seeing the flutter waves, that's the key thing. These are called flutter waves. Okay. So if you're seeing the flutter waves, again, you can have a variable conduction, and at that point you're pulling your hair out. But again, as long as it's constant, stays normal, actually the patient doesn't do too bad. So the P waves are in that characteristic sawtooth pattern. Gang, especially when you're taking your national registry, it's going to be very obvious that this is flutter waves, okay? Usually your QRS is a narrow complex, 0.12 seconds, okay? It's just that those saw teeth are usually between 250 and 300, all right? Now, the other ugly atrial rhythm and the ugly stepsister here, and this is atrial fibrillation. Oh, yeah, and you're going to come to learn to hate this, especially in our area, because it seems like to me that a lot of patients have this in our area. So what happens is the atria start to quiver. Okay, there are multiple foci. They just simply fibrillate. Okay. Now the bad part about this is that those little wavy lines, and I'm going to go show you an example of that. Again, I've got fibrillation waves all through here, but finally the QRS is going to say finally the AV node is going to let some signals through, or better yet, sometimes the AV node just kind of simply takes over. But most of the time, it will read a close by signal and then transmit that down to the ventricles. Now, to go back to the rod analogy, rod is gone, and all of a sudden we get every nurse from nursing come over and go, we're giving all these orders. And again, me, Dave, and Mel are going, wait a minute. I like yours, we'll let it through. I like yours, we'll let it through. I like yours, the rest of y'all are too much, okay? So the good news is that the AV node kind of serves as the gateway for that, all right? By the way, so when we determine this one, usually, and let's go back to A flutter for a minute. Guys, most of the time, A flutter is regular. Most of the time, it is regular, okay? Might be some irregularity to it if it's variable conduction. The thing about AFib is there's no discernible P waves, and it is grossly irregular. I'm going to use the term irregularly irregular. The heart rate, ventricle rate, is usually between 60 and 100, but if you have anything over 100 is considered a rapid ventricular response. If it's above 150, that's when we usually start to treat it. Now, our cool way of treating that, guys, by the way, is going to be cardizem, all right? We want to slow that down, okay? What I want to do is we got our ventricles up here that are spazzing out. We got our AV node that's coming down here, and so what this guy does, if he's picking up a lot of these signals up here, and he's transmitting them. So I got a heart rate doing this number, Yeah, that, by the way, that's going to be greater than 150 probably. What I will do is we will usually slow that down depending on their stability. If they are stable, we're going to use cardizem. Now, cardizem, as we all remember from physiology, that's kind of Debbie Downer, right? And what that does is it actually says, hey, I'm going to slow the conduction down through here. Think of it as adding another maybe fourth or fifth lead instructor to go, hey, we're going to put a bouncer at the door. We're only going to let so many signals through here. So that's what it does. In calcium channel blockers for Rapamil, they slow the conduction down through here. And so instead of having a heart rate of 150, it drops back down to a normal rhythm. And we're going to talk about that when we actually treat it. When you're treating a Flutter, or excuse me, AFib with RVR, one of the biggest things I like to do is when I give the cardizem, I actually like to give it in a bag. And I usually put it in a 250 bag and let it run in. That usually slows down your administration of a calcium channel blocker, which, as we all know, is a great thing. And by slowing that down, once I get the heart rate to where I want it, I can shut it off and then look up into my bag and see how much I've actually given. And then I can chart that, hey, I obtained a good heart rate by giving 5 milligrams of cardizem instead of maybe 25. So again, it's a lot safer. By the way, if the heart rate starts sneaking up again, you turn the diltiazem back up. If we get it down too slow, it's kind of hard to reverse. Okay, we can push some calcium to kind of reverse it, but that's not the way we really want to do it. I've seen AFib in the rates of 30s. I've also seen AFibs at the rates of 200, 220. So they can truly vary, all right? And when they're in AFib, we really want to do rate control. Now, the one other bad thing about AFib, guys, especially if they have been in it for a long time, remember that the insides of our heart have these little muscular fibril rings. They're turbinicles is what the actual term is. But what happens when they fibrillate is you'll get blood, and more importantly, blood will get in there and it will clot. Now, the problem with that is if we suddenly reset that, what's going to happen to all those clots in the atria? All those clots in the atria are then going to go down into the ventricles. From there, they're going to, and by the way, there's two sets of ventricles here, right? And so what's going to happen is it's going to go out into the body or go to the lungs. So I'm going to have blood clots galore, which is why, guys, when we have a new onset of AFib, one of the biggest things that we're worried about is a patient having a stroke. And I can tell you right now, we've actually caught a lot of people that are on new onsets of AFib that we've actually stopped them from having strokes. What they will usually do before they cardiovert these folks is they will put them on an anticoagulant therapy, put them on some heparin, or another anticoagulant so that they don't have the blood clots in the heart. They thin the blood out a little bit, then they cardiovert them, less chance for a stroke. If we're doing it in an emergency setting, guys, understand we're running the risk of having those little micro blood clots go out, and it can cause problems. So, guys, again, electrifying this rhythm is really, when I say a last resort, that's exactly what it is. Again, cardizem, diltiazem works really good for this rhythm, and I would highly recommend it as long as the patient will be able to tolerate it. All right, I'm going to get off my soapbox there because, again, the rest of this is practice strips, And we're going to definitely go over these in class, and we're definitely going to talk about them. So I hope you understand the atrial rhythms, and I'll see you guys on the next one.